It's my great pleasure to introduce Dr. Kikkeri Naresh, who's the inaugural speaker for our Grand Round series for the year. But before I introduce him, I just wanted to just issue some housekeeping items. So remember, you got an email from Brooke regarding the CME credit. So please click that link. There'll be a link at the end of the talk as well with a QR code if you forget. Also keep in mind that Brooke regularly sends out the schedule for a variety of seminars, including this Grand Rounds series as well. If you choose to join us in person at RR 134, there's the incentive of cookies that will be handed out at the end of the lecture as well. So I don't want to be eating all those cookies by myself, so come share some with us. So without further ado, I wanted to introduce Dr. Naresh, who's a full professor and head of pathology in the clinical research division at the Hutchinson Cancer Research Center, just down the street. So he comes to us after getting his medical training in India, at a variety of places at Mysore and Mumbai as well, and followed by further training and most recent stint for a long time actually at Imperial College in the United Kingdom as well. So he is an expert on hematolymphoid malignancies and has been invited by the WHO for giving his expert opinion on classification of these complex tumors. He's published over 250 peer-reviewed publications, extensive publication record, and invited speaking engagements as well. And so very excited to hear more about his talk today about classifying lymphoid neoplasms using modern genomic and precision medicine tools. So please, Dr. Naresh.
Thanks, Ron. And it's a real pleasure to be here. I've been in Seattle for now over 12 months, and this is the first time I'm visiting the department. So thanks to COVID. Okay. I think you have the link. This link is going to come again afterwards. And unfortunately, I don't have any financial relationships to declare. But I have a few other declarations. Part of my presentation is going to be on the WHO current work that I'm involved in. As Ram mentioned, I'm one of the 15 expert editorial board members. So some of the things that I speak might be biased by my current ongoing discussions. Another thing which might bias is I'm also the pathology lead on the Atlas of Blood Cancer Genomics, which is from the Duke University. But the rest of the things, I don't think it matters for my today's presentation. Just to quickly move the symbols up with the right. You can minimize it. Yeah, minimize. Minimize. Okay. Okay. So just to take you through the WHO classifications that I have been reading, I'm not too clear about how the second edition of the WHO classification was, but at least it was not very popular. It became popular, at least the lymphoma classification became popular with the third edition, and that was when I was actively learning. So, and before this, there was the real classification. So I was quite well versed with the third edition, then the fourth edition, which came in 2008, and more recently there was a revised fourth edition, which came in 2017. And now we are in preparation for the fifth edition, which is due to come next year. Just to give you a bit of background of how the classifications are done, this is not something specific for hematolymphoid, but in general, this is across all the areas. So there is an entity which is known as the International Collaboration for Cancer Classification and Research, which is the one which in the background sets the platform and sets the criteria of how these classifications need to be revised. These things feed into the WHO committees. So as I mentioned, there are about 15 editorial board members. And then this time we have changed some of the rules have changed. There are a larger number of experts who are on the authorship. There are nearly between 300 to 400 members on the authorship. And these include not just hematopathologists, but also include geneticists, clinicians, and a variety of other experts, epidemiologists, who all are interested in hematolymphoid malignancy. And the same thing is true for the rest of the WHO areas. So just to give you a brief, as a part of the introduction, lymphoma incidence is highly variable. As you can see, it varies from less than three per 100,000 population to, like in the US, is one of the highest incidence. You have nearly about 20 people among 100,000 people getting lymphomas. So this is a real problem, and I think the problem, as you can see here, varies from place to place. But in many areas where it is relatively less common, the population density is so high that one gets to see, and pathologists deal with a large number of lymphomas. So it's important to have a standardized way of classifying lymphomas. And more importantly, lymphoma, as most of you know, is not one disease. There are getting close to 100 different lymphomas. So unless one understands a clear understanding of lymphomas, it's very difficult to properly classify, manage, or have epidemiological data. As part of the classification system, I think these are the various areas we consider, like the etiology, the pathogenesis, clinical features. And as you can see, histology is only one component of all the things that we would consider in classifying disease. And of course, in the last 10, 15 years, molecular pathology, as it started, and then genetics, and now what we address as genomics, has majorly shaped our understanding of lymphomas. And these on the left will actually impact on what we decide as the definition of an entity, and also has how we lay down the criteria, essential and desirable criteria for diagnosis of these entities, further to stage the disease, and then to have prognostic and predictive biomarkers. So just to there are some subtle differences between hematolymphoid malignancies and other lesions. In solid organs, it's very well laid out. We understand what a benign tumor is, what is dysplasia, and what is in situ carcinoma, and finally an invasive carcinoma. And these concepts have come out over many years. We have a better understanding of the anatomic location. We understand that the esophageal cancer is something that we see in esophagus, and you don't have the same thing occurring in urinary bladder. Or within the entity of what are the subanatomic boundaries, what is mucosa, what is muscularis mucosa, so on and so forth. And many of these tumors have a capsule. And then we understand what is lymphomascular invasion. Whereas with lymphoid lesions or hematological lesions, none of these things matter. There are no anatomic boundaries. These cells are meant to circulate in the lymphatics and in the blood vessels. So the conventional definition of cancer becomes hard to apply to hematological malignancy. And within lymphoid lesions, the gradation, we don't have a benign lymphoma. What we have is a lymphoproliferative disorder, which are often clonal. Then we have in some areas what we understand as an in situ neoplasia, which can be an in situ lymphoma, and then a full-blown lymphoma. Just to give you again a background, in solid tumors, the concepts are much clearer. You have a benign tumor like a squamous papilloma. This is from the head and neck book of the WHO. And then you have severe dysplasia, where you have abnormal cells within the basement membrane, not going through the basement membrane, but these are neoplastic cells. And then you have invasive cancer, invasive squamous carcinoma. So these concepts are fairly clear. But in the hematological malignancies, there are many questions that come up, and these are quite key to understanding how we define disease. Is clonal expansion equivalent to a neoplasm? If you take a lymph node and you stain them with light chains, you can get a follicle which is completely filled with kappa-positive cells. Or a follicle in the same lymph node, you will see some follicles predominantly having kappa-positive cells and some having predominantly lambda-positive cells. And that does not mean that it's a neoplasm. And if you were to do clonality on immunoglobulin gene rearrangement, sometimes you may even find a clone, but that does again make it a lymphoma. So how big should the clone be? That's the next question. We don't have answers for that. How do we define a clone? Even for that, if you take a patient with HIV who is reacting to EBV, or a post-transplant patient reacting to EBV, you may have T cells of a limited repertoire, and all of them may be a clone, again, reacting to EBV. That doesn't make it a lymphoma. So these definitions are quite hard and have to be refined over time and with experience and with literature. So distinction then even after we define a neoplasm. What is a neoplasm and what is clinical malignancy? I will take you through an example of that. Here is the follicular lymphoma. We know follicular lymphoma is associated with immunoglobulin BCL2 translocation, the translocation 1418, which is a reciprocal chromosomal translocation. But if you were to take blood from an adult population in the US, you will find that half of the people will have very small numbers of 1418 positive B cells in circulation, nearly 50%. And if you take lymph nodes, which you have resected for various reasons for other cancers, and you stain them with specific antibodies, 2% of these lymph nodes, which are otherwise non-neoplastic, will have follicles which has all the features of a follicular lymphoma. The 2% of normal lymph nodes have what we currently call as an in situ follicular neoplasm. So how do we, and most of these patients do not develop a clinical follicular lymphoma. So here is one of those lymph nodes. You can see what looks like a perfectly reactive lymph node with all the sinuses maintained. The architecture is perfectly maintained. And then here we have done a CD10 and a BCL2 stain. There are few follicles which are very strongly positive as against the rest of the follicles. And again, in some of these follicles, you have cells which are very strongly BCL2 positive. And this is sine qua non of an in situ follicular neoplasm. And if you do here the double stain using BCL6 and BCL2, and part of the lymph node follicle has only BCL6 positive cells which do not express BCL2. These are reactive germinal center cells. These cells are larger. And then here on this pole of the lymph node, you have cells, small cells, which are co-expressing BCL6 and BCL2, which is part of the in situ follicular neoplasm. If you were to do a FISH analysis on this, these cells will carry 1418 translocation, but these patients will not develop a lymphoma, not develop a clinical lymphoma. So if we look now with all the along the B cell and T cell lineages, you've got many lesions which are by definition are clonal population, many of them who will not develop a clinical lymphoma, from monoclonal B cell lymphocytosis to different types of MGUS, to in situ follicular neoplasm, in situ mantle cell neoplasm, so on and so forth. And even on the T cell side, indolent T lymphoblastic proliferation, lymphomatoid papulosis, so on and so forth. These are all clonal expansions which not necessarily mean they are lymphomas. So again, taking along the follicular lymphoma, which I just discussed, you can see the earliest lesion of 1418 translocation doesn't even occur in the lymphoid follicle. It occurs in a pre-germinal center cell in the bone marrow, where at the joining region of the immunoglobulin gene. And these cells are released into circulation, and some of them enter into, as naive B cells enter into the germinal center and then recirculate there, developing additional abnormalities, both genetic and epigenetic abnormalities, finally resulting in situ follicular neoplasia. Many more changes are required for it to become a clinical follicular lymphoma. So there are, even with today's understanding of genomics, there are very few lymphomas that by the presence of a particular genomic abnormality, you can call it a lymphoma. These are actually exceptions to the rule. If you look at one such would be an ALK positive large, ALK positive anaplastic large cell lymphoma. Here you've got a abnormal infiltrate, and these cells are positive for ALK and positive for CD30. And the ALK expression, which should not be seen in normal lymphoid cells, is seen both in the nucleus and in the cytoplasm. Similarly, you have an ALK positive large B cell lymphoma or a large B cell lymphoma with IRF4 rearrangement. So there are a few more where you can actually define a clinical malignancy based on a particular genomic abnormality. But in most other, this is the reality. We define a lymphoma not best by morphology or by genomics. You define by multiple parameters from morphology, epidemiology, immunophenotype, genomics, pathogenesis, and clinical presentation. Another, very few we know the etiology. Recently I was in discussion with on chronic lymphocytic leukemia. One of the persons, he must be in his 80s now, Kanti Rai. Some of you may know from the Rai staging system. He is one of the authors on the CLL. So we were asking him, nagging him, saying, what is the etiology of CLL? And he said, we do not know the etiology of CLL. And that is true for many other lymphomatous patients. So many of them we know the pathogenesis. We know a lot about pathogenesis. In fact, the write-ups on pathogenesis is even longer than the microscopy or anything else. But we know very little about etiology. One place where we say we could probably know the etiology, the rare lesion, what we call the breast implant associated anaplastic large cell lymphoma. 1 in 3,000 to 30,000 women with implant develop anaplastic large cell lymphoma. And the lymphoma has also been associated with a particular type of implant. The textured surface of the implant is said to produce an immunological reaction, which results in this T-cell lymphoma, which expresses CD30 and is ALK negative. But again, one has to be careful. Not all lymphomas that occur in a breast implant site is actually this entity. You can also get a fibrin-associated large B-cell lymphoma, which is EBV positive, and there are about 3 or 4 case reports which have come out recently. So in very few, we actually know the etiology. So if we start looking at the pathogenetic drivers of classification, because these are the ones which are going to mold our classification, I just picked up 4 possible main aspects by which actually drives our thinking. The most important is cell of origin. We have been always glued to this concept that for every malignancy, there is a normal counterpart, and we haven't got out of it yet. And then we have some lymphomas which have got a pathogen association, so that we can look at it as an important pathogenic driver. Then, of course, the genomics and genetics. And what I'm not going to speak today much is about the tumor microenvironment. I think that is a key factor as well. One of the publication that I really got excited when I was in the early days as a lymphoma pathologist was this study which came in 2000, the molecular subtyping of diffuse large B-cell lymphoma by Aliza Day. For the first time, gene expression actually showed that you can divide diffuse large B-cell lymphoma into 2 subsets, one the germinal center B-cell-like, which has a better prognosis, and activated B-cell-like, which has got a poor prognosis. And this also had biological sense. When you looked at these lymphomas, they were very different. One of them you could clearly identify was derived from the germinal center B cell. There were ongoing somatic hypermutations, whereas in the other one, it was mutated immunoglobulin gene, but did not have an ongoing mutation process. And then also the genetic lesions, like the B1418 translocation was restricted to the germinal center B cell-like, and the BCL6 translocation restricted to the activated B cell-like, DLBCL, so on and so forth. So it made a lot of biological sense. And so this became, even though in many areas we know a lot about genomics, this is one of the few which has entered into the WHO as a subtype of diffuse large B-cell lymphoma. So when we put our concepts, what we know today on the B-cell ontogeny into what we know on lymphomas, we can see that we understand the naive B-cell view are similar to what CLL cells are similar, or a subset of CLL cells are similar to what we call a naive B-cell. Mantle cell lymphoma is again similar to the cells within the primary follicle or in the mantle zone of a germinal center. And within the germinal center, you've got multiple different types of lymphomas. You have the centrocyte, where the phenotype and the genotype is similar to the germinal center type of diffuse large B-cell lymphoma and a follicular lymphoma. And then you have the pre-plasmablast, or some people would call it as a post-germinal center B-cell, which gives rise to the ABC type of diffuse large B-cell lymphoma. The memory B-cell, which mimics the CLL or the marginal zone lymphoma. And then we have the myeloma, which has features similar to plasma cells. So this was in 2015 what we understood the best at the time. Then we also understood when we looked at CLL was not one disease. You can get CLL, which has got a phenotype like a naive B cell, where the immunoglobulin gene is completely unmutated. It looks like the germline configuration. Then you have CLL cells which have got limited somatic hypermutation, which expresses usually the IGH-V3 along with the B312 and B321 complexes. And then you have the mutated type of immunoglobulin gene. Some of the mutated ones having undergone class switch recombination, and some which have not undergone class switch recombination. So we end up actually with 4 different types of CLL, but 2 of them are universally accepted as 2 subsets, one with unmutated immunoglobulin gene and one with the mutated immunoglobulin gene. Now I showed you the understanding in 2015, and now in 2020 we understand it a little more. We understand that within the germinal center we have the dark zone and the light zone, which we knew for a long time. But we now know that a set of B-cell lymphomas have the genomic configuration and the phenotype of a dark zone phenotype, like the ones which have got the double hit lymphoma. And some of the germinal center B-cell lymphomas which have got a very aggressive behavior, they have a dark zone phenotype. And this can be seen on gene expression analysis, and probably in years to come, we will have much simpler solutions to identify the dark zone phenotype. And then the light zone cells are the ones which I earlier said will give rise to the rest of the diffuse large B-cell lymphoma and myeloma. So within 5 years, there has been a significant progress on this front. Similar to what I described with the B-cell malignancies, even the T-cell malignancies, we can try to see similarities between lymphomas and specific types of T-cells. The one where the concepts are far more clear-cut is the TFH subset, like what we call the angioimmunoblastic T-cell lymphoma. Those have all the features of a follicular helper T-cell. Similarly, we can dissect out other T cells into those expressing GATA3, those expressing TBX21, both of which are types of peripheral T cell lymphoma. And then we also have the Th17 type of T cells, which have anaplastic large cell lymphoma has features of Th17 type of T cells. And then you have the adult T cell leukemia lymphoma, where at least a subset of these express FOXP3 and have features of regulatory T cells. And now the way we are developing the concept is within the TFH umbrella or the T follicular helper lymphomas, we have the prototype which is the angioimmunoblastic T-cell lymphoma, but there are two other lymphomas which share the phenotype and the genotype. One is the follicular T-cell lymphoma, and the other one is the nodal peripheral T-cell lymphoma of TFH phenotype. Then we also have some lymphomas which are where we make a diagnosis by the association with pathogen, and at least 4 of them are clear-cut. One is the EBV-associated diffuse large B-cell lymphoma. Then we have the HH-8 positive diffuse large B-cell lymphoma, NOS, which is associated with HHV8. Then we have got a primary effusion lymphoma, which is always associated with HHV8, but frequently co-infected with Epstein-Barr virus. Then adult T-cell leukemia lymphoma associated with HTLV1 virus. So all these are defined by their associations with specific viruses. But one has to also realize there are many other lymphomas where a proportion of these lymphomas can be associated with viruses, and these are not defined by the viral association. Like the Burkitt lymphoma, if you go to Africa, in endemic Burkitt lymphoma, almost every single case is EBV positive. But outside of Africa, only about 20 to 30% of the cases are EBV positive. Similarly, classic Hodgkin lymphoma, plasmablastic lymphoma, only a proportion of plasmablastic lymphoma, probably around 70 to 80% are positive. But with other lymphomas, only about 20 to 30% of them are positive. Primary effusion lymphoma, about 70% of 80% of them are EBV associated. Then again, we have other mold lymphomas, which can be associated with bacteria, with different viruses. So in this, the association with an infective agent does not define the disease, but it is a frequent association. Just put up the picture of how the HTLV1 carrier status exists in this country. Most often people think HTLV1 is endemic only to specific areas, which are here in dark brown, like in Africa, Japan, the Caribbean. But what people don't realize with the current immigration and various other factors, places like the North America, places like India, Australia, there is a significant population of HTLV1 positive carriers. So although when people do not think about it, I think it's important for in any T-cell lymphoma to consider that this could be possibly a adult T-cell leukemia lymphoma until proven otherwise. Just to take this, then we will look at a few slides to see how genomics and genetics have actually molded our current understanding of disease classification. I will take you to 3 major principles here: the balanced chromosomal translocations, somatic mutations, and copy number alteration. So if we take MYC rearrangement, this is one of the first rearrangement that was detected in Burkitt lymphoma. And what we see here is that though MYC rearrangement is typically seen, it can be seen, it is not restricted to Burkitt lymphoma. It can be seen in many other lymphomas like diffuse large B-cell lymphoma, hybrid B-cell lymphoma, MS, plasmablastic lymphoma. Many of the transformations from indolent to aggressive B-cell lymphoma, all these 4 can have MYC rearrangement. But for the diagnosis of Burkitt lymphoma and for a double hit lymphoma, or what we call high-grade B-cell lymphoma with MYC and BCL2 or BCL6 rearrangement, it is in their definition. You need to demonstrate that MYC is rearranged to make a diagnosis of these 2 entities. But people think that MYC rearrangement is a simple concept and is a a dichotomy between MIC rearranged and not rearranged. But when you actually closely look at how it impacts on diagnosis and on patient behavior, it depends on whether a lesion has got what is the partner of the immunoglobulin chain. In diffuse large B-cell lymphomas, where you have an immunoglobulin partner, those cases do badly, whereas those with a non-immunoglobulin partner, they may not do as bad. And then whether it's a primary event or a transformation event, then whether MIC is rearranged alone or whether there are additional rearrangements of BCL2 or BCL6. These have a very aggressive behavior. But in all these things, what has been forgotten, earlier people used to look at all these translocations using classical cytogenetics, where we could see whether it's a simple MIC or a complex MIC. But currently with FISH studies, we don't have the data. I say a MIC, which is a simple MIC rearrangement, is not the same as a MIC rearrangement, even without BCL2 and BCL6, but with a one full page long cytogenetics report. So complex MIC behaves in a very aggressive manner, and that somehow has been lost in the literature in the recent literature. If we take BCL2 rearrangement, again, this is, though it is typical of follicular lymphoma, it is not required for a definition of follicular lymphoma. The only entity where BCL2 rearrangement is required for a diagnosis is a double hit lymphoma. Other lymphomas like follicular diffuse large B-cell lymphoma, other high-grade B-cell lymphoma, NOS, even rare CLLs can have a BCL2 rearrangement. And within the follicular lymphoma, of course, it guides us about the biology of the disease. The classic follicular lymphoma has a BCL2 rearrangement, but you have nearly about 15 to 20% follicular lymphomas which are BCL2 rearrangement negative. They may have BCL6 rearrangement, or they may have many other alternative mechanisms like 1p36 deletion, TNF receptor SF14 mutation, or STAT6 mutation. And these lymphomas, these types of follicle center lymphomas, are also quite distinctive. You more often see this in in pediatric follicular lymphoma, in diffuse follicular center cell lymphoma, and so on and so forth. Again, with cyclin D1 rearrangement is typical of mantle cell lymphoma. All 95% of mantle cell lymphomas will have cyclin D1 rearrangement. Nearly about 20% of plasma cell myelomas will have cyclin D1 rearrangement. But in a mantle cell lymphoma, is it required for a definition of mantle cell lymphoma or a myeloma? No. Now, 5% of mantle cell lymphomas will not have a CCND1 rearrangement. They could have CCND2 translocation, or they can have other mechanisms for CCND3 overexpression. When we look at T cell lymphomas, we try to, again, some of the genomic abnormalities, like the TET2 and DNMT3, which is frequently seen in angioimmunoblastic T cell lymphoma, is not even lineage specific. It can occur at much before the cell is committed to a lymphoid lineage. You can see the same mutation in the same patient in myeloid cells. So using mutation studies to define diseases can be tricky. You've got to pick the right candidates to come to a diagnosis. Supposing the patient has got IDH2 mutation or a ROA mutation, probably you're dealing with an angioimmunoblastic T cell lymphoma if it's a T cell proliferation. So there are very few entities which you can use directly to say, okay, this mutation equals to this disease, even with a lot of careful thinking. Like if you have a MYD88 mutation in a small B-cell lymphoma with an IgM paraprotein, you're very likely dealing with a lymphoplasmacytic lymphoma. If you have a BRAF mutation in the context of a splenic B-cell lymphoma, you're dealing with a hairy cell leukemia or IDH2 mutation, which I just mentioned. Like a MYD88 mutation can be seen in diffuse large B-cell lymphoma of activated B-cell type, or a BRAF mutation can be seen in Langerhans cell histiocytosis and other histiocytic neoplasms. Copy number changes that are this is probably the only entity where you define an entity based on a copy number change. And this entity came into existence because there were Burkitt lymphomas where you could not find a MYC rearrangement. And careful analysis of cases which lack MYC rearrangement but has many of the phenotypic features of a Burkitt lymphoma, both morphological and immunophenotypic features, these cases have a peculiar rare abnormality of the 11q, where part of the 11q is amplified and the telomeric part of 11q is deleted. So this is a specific copy number change which occurs, and this relates to a specific entity. But again, this abnormality can be seen in other lymphomas, but in the right context, this is used to define a particular disease. Then there's a long list of things where we can see different mutations. These are frequent associations. You will see a large number of, so using a wide mutation panel is definitely useful to come to an informed diagnosis. But we can't say that this mutation equals to this diagnosis. So one has to be. And similarly, we have a long list of numerical abnormalities that happen, but again, which are frequently associated but are not defining of specific lymphomas. And so is true of translocations in lymphomas. So there are frequent associations which are helpful in diagnosis but do not define the disease. The last thing I want to pick, compared to all these things, is clinical presentation is a key feature. There are many lymphomas which are defined by clinical presentation. And once you define that lymphoma, then the particular clinical presentation has specific morphologic correlates, immunophenotypic correlates, genomic correlates, and it impacts on clinical outcome. And here is a long list, and many of these are actually skin lymphomas. In skin lymphomas, without knowing the clinical presentation, then it is extremely hard to make a diagnosis. But even outside of skin, like the primary mediastinal large B-cell lymphoma, it's got a classic presentation. So clinical presentation is quite key in making a right diagnosis in lymphomas. Then the next question that comes up is, how do we define a disease subtype? What is a subtype of a disease? What are the drivers for these subtypes? You can have morphology as a driver, you can have epidemiology, you will see some examples, clinical presentation, and less often phenotype and genomics can actually be drivers for disease subtyping. More often, genomics and phenotype are drivers for disease stratifiers. In the current day of precision medicine and stratified medicine, these become extremely important. Here are some examples which are for subtyping. Follicular lymphoma is graded on morphology. The number of centroblasts into grade 1 to 3A, and 3 is subdivided into 3A and 3B. Mantle cell lymphoma, again based on morphology, subdivided into classic, blastoid, and pleomorphic. Burkitt lymphoma subdivided by epidemiology, endemic, sporadic, and HIV, or immune deficiency associated. Then you have mycosis, which is subdivided by the clinical appearance, the patch and plot and tumor stages. Then again, primary cutaneous CD30 positive LPDs, which are subdivided both by clinical and histological grounds into lymphomatoid papulosis and cutaneous ALCL. ATLL subdivided by both by morphology and clinical patterns. Then things start getting confusing here a little bit when you start seeing how various genomics and other factors are these subtypes or these stratifiers. If you take diffuse large B-cell lymphoma, we have accepted based on genomics that germinal center and activated B cells are actually two subtypes of diffuse large B-cell lymphoma. We don't have a consensus in CLL. I brought up this question, but it wasn't received well. Can we call them, can we define a CLL which is unmutated, mutated, or different stereotypes? Probably the time is not right yet. In follicular lymphoma, can we say follicular lymphoma with 14, 18, and 14 is positive and negative? Again, time is probably not right. In primary cutaneous marginal zone lymphoma, we know those which have got a class switch, where you have IgG or IgG4 positive marginal zone lymphoma behave in an extremely indolent manner, whereas those which are IgM positive, those behave in a more aggressive manner. So again, these high-grade B-cell lymphoma, morphologically subdivided into intermediate and blastoid, so on and so forth. So questions are ripe with all these things, and some of these things may be addressed in the 5th edition, and some may have to wait for the 6th edition. Just to give you the science behind this, if you look at CLL and you look at the mutational status, here let's just look at the overall survival curves here, and you can see here the one in black here is the one with mutated CLL. There, almost 40% of them have a long-term survival. Whereas the one with unmutated, the one in gray here, they seem to have at least a 30-35% difference in survival as compared to the mutated type. Unmutated is definitely worse. And then within the partially mutated ones, you have certain stereotypes which behave very badly. So these kind of data actually strongly push us to classify CLL based on the immunoglobulin mutation. An important thing for anything to change in the WHO classification, you should be able to use the classification across the world, or at least major part of the world. It's not just adequate if you can use it in the US or in the UK or Europe. It has to be useful everywhere else. Anaplastic large cell lymphoma. For a long time, we understood only the ALK positive anaplastic large cell lymphoma. We clubbed all the other ones as anaplastic large cell lymphoma, ALK negative. But we know now there are two subsets. The just 22 positive anaplastic large cell lymphoma. Is that a distinct entity? We are not sure, because some of the cutaneous anaplastic large cell lymphoma can also have this rearrangement of just 22. TP63 rearranged anaplastic large cell lymphoma is another subset which expresses P63 strongly. And then you have a subset which don't have either of any of these three translocations, ALK or DUS22 or TP63, the triple negative group, which is quite aggressive. So when you look at the survival of these patients, you can see that the ALK positive one and the DUS22 rearranged ones have the best survival. Then in the TP63 rearranged one has the worst survival, and the triple negative one has a bad survival, but not as bad as the TP63 rearranged anaplastic large cell lymphomas. When you look at peripheral T cell lymphoma NOS, there are two important groups based on gene expression. One is the TBX21 expressing peripheral T cell lymphoma. Then you have the GATA3 positive or expressing peripheral T cell lymphoma. Those with GATA3 expression, they also express CCR4, and they are the ones which do badly. And so again, this is now there are many proponents who, and there's quite a lot of data to support that we may want to divide the peripheral T cell lymphoma into these two entities. But I suspect this may not get through the current classification, or maybe provisionally accepted, and we need more data. A lot of things have happened on diffuse large B-cell lymphoma, and this really signifies how our current thinking of genomics, how to use it in the clinic, is this is a blueprint for that. And the first thing which came up in diffuse large B-cell lymphoma outside of the subtypes of GCB and ABC was the MYC expression. Those independent of MYC translocation, those cases which co-express MYC and BCL2 here in blue, those behaved very badly. So these were called double expressors. So this is a stratifier. This is not a subtype. So we, in the current way of we do report those cases which co-express MYC and BCL2. But one should not mistake this as a subtype. This is a clinically important information on the prognosis of the patient, but we may still not know how to treat them differently. Then the next thing which came more recently was within the GCB and the ABC, we identified, I spoke to you about the dark zone signature. This is also called a molecular high-grade signature. And a subset of GCB, diffuse large B-cell lymphoma, have the molecular high-grade signature. And some of them have got a MYC rearrangement, some of them are double hit. And then you have some, nearly 50% of them do not have a MYC rearrangement, but the gene expression is very similar to those with MYC rearrangement. And this can be separated out from the diffuse large B-cell lymphoma germinal center subtype. And a very tiny fragment of the ABC subtype can also have a molecular high-grade signature. And the important thing, this was from the Remodel B trial in the UK, which not only did it segregate the molecular high-grade diffuse large B-cell lymphoma, when these patients were treated with R-CHOP along with bortezomib, you could actually revert and improve survival in these patients. So here was one study where not only did it define a molecular subset which was more aggressive, but you also said these can be treated differently and you have a better survival. This is a more recent paper now. Diffuse large B-cell lymphoma is, apart from the GCB and the ABC, is being defined based on genomics into 6 groups as in here. And these 6 groups, a combination of mutations, copy number changes, translocations, they come up with these 6 groups. And these 6 groups also have, like the MCD group, most of the MCD group is ABC. Most of the N1 group, the Notch1 mutation, again, has the gene expression of ABC. Similarly, the EZB group, which is EZH2 mutation and BCL2 translocation, most of it are GCB, and the ST2 group is also GCB. But the other 2 groups are a mixture of GCB and ABC. But even when you define on these characteristics into 6 groups, you still have nearly a third of diffuse large B-cell lymphoma, where you're left with just saying that the GCB or ABC and not be able to put into one of these 6 categories. And when you look at these, the reason why, at least this paper suggested it's worthwhile to look at it in this manner, was that each of these, though these subsets can be derived from the ABC or the GCB subset. You can target specific pathways, like you can use BTK inhibitors, you can use PI3K inhibitor, BCL2 antagonists, so on and so forth. So here, the proponents of this classification are suggesting that classifying diffuse large B-cell lymphoma based on genomic characteristics will help us treat patients differently with specific molecules, with specific targets. And they had data to support it, and the data was from from multiple institutions, and it stayed good when they were tested it on multiple cohorts of patients. But what we have learned from previous experiences, like if you go back to 1980, I mean, this is what we have read. 1980, there was a lot of fights going on, and finally the NCI came up with the working formulation, and they divided all lymphomas into 3 groups: low grade, intermediate grade, and high grade. But the problem with this kind of an approach is that the treatment is continuously changing, and you can't change classification continuously as the treatment changes. So making a treatment impacts on outcomes. So what is bad disease today may not be a bad disease tomorrow. And so we have to be careful in using principles of treatment and targeted approaches to actually classify diseases. So in the current classification, even when you go back to the 2017 classification, there are very few lymphomas where you use the word chronic or a high grade or aggressive. There are very few. Most of them are defined on other attributes, but not on outcomes. Of course, the diseases have got specific correlates with outcomes, but those are not the defining feature. So another note, the next edition is very likely that we will have some new entities. I think the ROM may be happy with the monoclonal gammopathy of renal significance will be there. And then there are many other things here, like the B lymphoblastic leukemia. There are many other specific rearrangements have come out in the literature, so those will be independent entities. And as I said, some of the indolent clonal marginal zone expansions, which we are currently calling lymphomas, should they be really called lymphomas and permanently a person stamped as a cancer patient? The ones especially with expressing IgG or IgG4, so those we need to rethink. And then we have like the plasma cell neoplasms associated neoplastic syndrome, like the Point syndrome, HHV8 unrelated effusion large B-cell lymphoma. And we are trying to also bring some of the entities which were earlier described with different names. One of the things that we are attempting at is how different is a PTLD from an iatrogenic LPD. So there are many commonalities. The basic thing is there are secondary immune deficiency. So how can we bring things what we initially thought were different entities under one umbrella? So that's another. So we are both dissecting and trying to bring things together. There are quite a few people from our department, from our institution, from the Hutch and the UW, who are on the authorship of the new classification. So a lot of our department is working on this. So with that message, I think that must be my last slide. Hope I've not gone over my time.
Thank you. I mentioned to the audience to put the questions in the chat, and I can read them to you, or if you like.
Okay.
Or the audience members, if they'd like to, they can also unmute to ask their own question. Marie, if you'd like to do that. If not, I can read it out.
You might not be able to hear them.
Oh, I should read it out, maybe. Okay. The first question let me go. Is it known why patients with peripheral T-cell lymphoma NOS expressing GATA3 have a poorer prognosis compared to TBX21? I think this is probably really early. We have one really major study coming from Nebraska. I think we need to look at more data sets before we are able. When some of the expression pathways are different, but you also have normal correlates. You have a subset of T cells which normally express GATA3. If you take any reactive lymph node and stain with GATA3, you will see T cells which are GATA3 positive. But still, I think this needs to be reevaluated on multiple data sets before we have any definitive answers. The next question I have is on, do you have an opinion on the significance of MYC amplification? I think that's a really good question. If you look at the double expressor data, the double expressor data is not limited. The double expressors are not limited to germinal center subtype. You can have activated B cell type diffuse large B cell lymphoma, which expresses MYC. And if you look at most people have not reported the FISH studies properly in those cases. Many of them, which lack MYC translocation, have a MYC copy number change. And so I think it's important data, but the data that is available in the literature is not uniform to have recorded it. So it's been a difficult question to address. But I think MYC amplification is important. Laurie says, will the WHO continue to consider BCL6 rearrangement as part of WHO paradigm or just MYC and BCL2? It's very likely that the BCL6 rearrangement is going to be dropped. Again, we'll have to wait till we have the final chapter written because there's going to be a lot of discussions on this. But the general, the direction that most people are thinking is that we need to drop the BCL6 because they don't really behave that badly.
I had a question about the mutated CLL as well with the IgG, I guess. How do you say mutation?
B-region mutations.
What proportion of CLL do they represent?
Nearly half.
Really? Wow.
Nearly half. The ones which really do well go on and on. So many of them are mutated.
You have seen cases actually with those with clonal IgG kappa, for example, causing kidney problems, and so. We were like, well, what about these? So we think about a CLL paradigm as well.
Yeah, I think that's the MGRS. I think we had just started a MGRS clinic in Imperial. And most people think paraprotein is only seen in a few types of lymphoma, but paraprotein and the paraprotein associated problems can occur in a variety of B-cell lymphoma.
And another question I had is, it always strikes me when I look at the WHO classification for these neoplasms, that technology is such a huge driver for that, right? So what new technologies are being incorporated into the WHO classification scheme? Which ones do you think should be or are on the horizon for that?
The Society of FRCPath meeting, which is going to happen in a month's time, the regions which were submitted for that all went through a single pipeline which could look at both DNA and RNA. So the innovativeness of that particular pipeline, which actually I have seen it offline, is that it gives recording of the mutations. Though it captures the whole exome, it presents the specific mutations that we are interested in lymphomas. Also gives rise some indication of the copy number changes and the expression data according to the published literature. But you can also replace some of the things like is CD10 expressed. You can look at the expression when the CD10 is expressed. If a particular virus is present, if it is present beyond a particular copy number, it can tell you this virus is positive. So through a single pipeline, you can get data on chromosomal translocations, copy number changes, expression, mutations. Whether this is going, this is being tested. It has to be tested for years. I would very much like for us to be the beta testing center or something like that. Whether it will replace, and some of the current technologies can it replace clonality? Because the same genomic information that we get, if it is of the depth enough, we should be able to say that there is a clonal population present. So all the current modalities can be replaced with very few platforms. That's the question that's being addressed.